Today we're going to talk about usual interstitial pneumonia. So in order to understand this disease, it's important to understand what is the interstitium. So then the interstitium is basically a network of connective tissue that envelops all the lung parenchyma. So what we have here is a diagram of the lung, and inside this diagram of the lung we see lines, and those lines are basically connective tissue that is supporting this lung parenchyma, and this is called the interstitium. So we have three types of interstitium. We have the peribronchobascular interstitium, which is ending on the centrilobular interstitium. And then we have the intralobular interstitium, which divides all the parenchyma inside the secondary pulmonary lobule. Remember that secondary pulmonary lobule is the functional unit of the lung. And then finally, we have basically the peripheral interstitium, which is the interlobular septa and subpleural interstitium. And the interlobular septa divides each secondary pulmonary lobule. So then the interstitium will be affected into a subtype, or basically more than 130 pathologies of the lung. And the pattern of usual interstitial pneumonia is just one of those 130 pathologies. And basically, I wanted to talk about especially of usual interstitial pneumonia because it's the most common of these 130 pathologies that the pneumologist of the internist will see in his or her practice. Of course, it will affect the interstitium, and eventually what is going to produce or this disease is extreme fibrosis and destruction of the architecture of the lung, and eventually it will produce honeycombing, and eventually it will produce impairment on the gas exchange in the lung and dyspnea of the patient. So the etiology is very obscure sometimes, but in general, studies have shown that epithelial injury is the base of the activation of fibroblasts, and also it has been implicated the Th2 cell activity. Of course, smoking is a very important risk factor for these patients. Usually, they have a history of being smokers or ex-smokers, and it's very important to ask about it when we are especially admitting this patient into the clinic. And then viral infections or microaspirations in the context of a gastroesophageal reflux disease. Also, people have been studying genetic factors, especially mutations in the telomerases, which has been implicated in aging of the fibroblasts and eventually in the position of collagen and fibroblasts into the lungs. So what we have at the end of all of these mechanisms is this molecule. So the transformation growth factor beta-1 is the one that has been implicated into this whole inflammatory response, and eventually this factor will produce fibroblast activation, and fibroblast activation will end up into deposition of collagen and extracellular matrix into the lung interstitium, and it will produce fibrosis. So then, as a result, the pathologist will see this pattern, especially in the usual interstitial pneumonia. He will describe to us that the patient has foci of fibroblast, and then also the position of extracellular matrix, and some areas even of honeycombing. Then this is the appearance of the whole lung. You see that it affects more the bases and also the periphery of the lung. You can see here honeycombing, extreme honeycombing on the bases and the subpleural parenchyma, and then you can see areas of fibrosis in between the honeycombing formations. So this is also the appearance of the lung on a reconstruction from high resolution CT, and then you can see how honeycombing is appearing. So then clinically, the patient will go into the clinic and go to you and complain of a dyspnea that might be in crescendo in the last months or in the last years. Usually the patient will refer a dry cough, and also the patient will have no complaints about loss of weight or other kind of signs of symptoms that can put cancer on the list. But remember that these patients with idiopathic pulmonary fibrosis can have a more risk of cancer, so it's important to think about it when you are seeing these patients. And then at the physical examination, you can hear on the lungs that they have very dry crackles, especially at the end of the inspiration. So this is an important sign that you should keep in mind. So then, in summary, we have a lady or a gentleman. Usually is more common in men, perhaps because men, they smoke more frequently, and is men in their 50s or 60s or 70s that complains of dry cough and dyspnea. Usually this dyspnea is in crescendo and impairs exercise. The patient will say to you that he feels more tired, he feels churns of breath when he exercises. So then the radiograph is not the best diagnostic method to end up thinking about um, a pulmonary interstitial disease, but um, perhaps in the late phases and with all the elements of the clinical evaluation, you can have a high degree of suspicion. But in general, what you can see, especially of um, intermediate levels of the disease, is a subpleural reticular pattern. Usually at the beginning, the radiograph can be normal, so um, don't be don't be distracted by this find. If you are suspecting pulmonary interstitial disease, you should have a high resolution CT at hand. So then what we can see here in the radiograph is a subpleural reticular pattern. You can see how reticulation is important, especially at the subpleural space and especially at the basis. But when the patient has more compromise, eventually it will end up in this appearance. It will be very, very reticular, right? It will be a very manifested pattern. So you can see you can see here some areas of honeycombing, and then of course the best imaging method is the high resolution CT. Even sometimes even without biopsy, you can have the diagnosis of um, idiopathic pulmonary fibrosis or even other diseases of the interstitium. So always ask for an HRCT. Don't stop at the radiograph. Always ask for this method. So then here we have the appearance of the disease in the high resolution CT. So we have here that in this patient was complaining of dyspnea, shortness of breath, and then he ended up having this pattern. So we can see here interlobular thickening, especially subpleural, is always basal, as you see in this cut in the axial axis. And also keep in mind that the pattern is mostly subpleural, basal, and posterior. And then a lot of intralobular thickening. It's very uncommon that the patient will have interlobular thickening, but it can happen. So keep in mind that also. So as the disease progresses, you can have even traction bronchiolitis. So then if this arrow is pointing at the this traction bronchiolitis, you can see many of them. This is one, this is another. Here we have also many of them, and you can see areas of fibrosis, especially intralobular thickening or fibrosis, and even you can see especially areas of ground glass opacities. But these ground glass opacities maybe can be the product of inflammation as a result of activation of the disease at some point. And then with time and progression, you can see honeycombing, especially on the basis, as I said, and also on the posterior part of the lung. So then here you can see honeycombing formation, even areas of air trapping, which is very common between these patients. They can have like a pattern of emphysema mixed with the pattern of honeycombing. You can see here also there is extensive fibrosis, intralobular fibrosis. And then I show this picture to point out that the pattern is always basal and basal, subpleural, and posterior. Here you have a coronal cut of the lung, and then you can see how the pattern is eventually very posterior and also subpleural and basal. Okay, so this is all about. I hope you enjoy it, and don't forget to subscribe to the channel and wait for more videos. Thank you very much and have a nice day.